Hi, welcome to PsiHub, where we analyze and scrutinize the forensic psychology literature to hopefully cultivate your interest in this fascinating field of study. Today, we will ask ourselves, what exactly is psychopathy, why many consider it to be untreatable, and why that might not actually be the case. In other words, can we treat the untreatable? In 1976, American psychiatrist Dr. Clickley published the 5th edition of his now classic treatise, The Mask of Sanity, which is often credited as being the foundation for our modern conceptualization, or just in general, how we think of psychopathy. In short, he described the typical psychopath as someone who conceals their poor emotional responsiveness and deviant behavior with a mask of positive social adjustment. In his work, he outlined 16 criteria of the prototypical psychopath, which include items such as superficial charm, unreliability, and poor affective reactions, which can further be grouped into 3 distinct categories. These being positive adjustment indicators, which encompass good social adeptness and absence of delusions; behavioural deviant indicators, which encompass irresponsibility and impulsive antisocial acts; and finally, emotional unresponsiveness and impaired social relatedness indicators, which encompass lack of remorse or shame and deficient insight. Notably, although Cleckley did not describe the typical psychopathic patient as violent or criminal, most other writers instead describe psychopaths as emotionally cold and cruel, as violent and dangerous. Indeed, surveyed members of the general public and jury members alike often think of infamous serial killers when asked to think about typical psychopaths. Furthermore, although only about 1% of the general population meet the criteria for psychopathy, up to 25% of the prison population meet the same criteria. So it comes to no real surprise that many would assume psychopathy to be inherently criminal, violent, and aggressive. We could also, arguably, thank the now infamous psychopathy checklist, the PCLR. In short, the Psychopathy Checklist Revised, the PCLR, is a clinical tool designed to assess psychopathy. Note that I say assess rather than diagnose, because psychopathy is not a clinical diagnosis recognized by the DSM-5 nor the ICD-11, the quote-unquote Bibles of diagnostic psychiatry. In fact, the closest clinical diagnosis that we currently have to psychopathy is antisocial personality disorder, ASPD, though I must stress that these ASPD and psychopathy are not the same thing. Typically, although most psychopaths do also have ASPD, the inverse is not true. The checklist assesses 20 personality and behavioural traits, 18 of which load onto 2 main factors and 4 facets. More specifically, Factor 1 assesses callous and unemotional personality traits, whereas Factor 2 assesses observable lifestyle and antisocial behaviours. These items are then scored as being either not at all applicable, somewhat applicable, or highly applicable to the patient, represented by a score of 0, 1, or 2, respectively. Importantly, when assessing any patient, clinicians must refer to as many reliable sources of information as possible, which start with the interviews they've had with the patient, as well as the patient's institutional and psychiatric records, in order to get an as reliable assessment as possible. Indeed, given the highly stigmatized label that psychopathy holds, it's completely unethical to even remotely seriously attempt, to assess anyone as a psychopath using the PCLR based solely on, media appearances alone, for example. So all in all, PCLR total scores range from 0 to 40, with the diagnostic cutoff score for psychopathy being at 30 in North America and 25 in England and Europe. Now, to put these diagnostic cutoff scores into perspective, non-offending young people score an average of 2.1, with offenders scoring on average 13. Despite the undeniable role the PCLR holds in clinical practice and research alike, many researchers criticize just how much this assessment tool emphasizes criminal activity in its scoring criteria. Indeed, a quarter of the PCLR's 20 items directly relate to antisocial behavior, most of these items requiring specifically evidence of criminal behavior for a score above 0. Now, this emphasis on antisocial behavior falls in line with Hare and colleagues' perception of psychopathy, who argue that antisocial behavior is a defining feature of psychopathy. However, other researchers instead argue that antisocial behavior is a potential downstream consequence of psychopathy. This perspective is often illustrated by Cook and Michi's three-factor model of psychopathy, as they entirely removed all PCLR items relating to antisocial and criminal activity and criminal behaviors. This is not to say, however, that the authors entirely deny the correlation between antisocial behavior and psychopathy, but instead they argue that because antisocial behavior is a potential downstream consequence of psychopathy, it should therefore not be considered a defining feature of psychopathy and therefore should not be assessed when assessing psychopathy. But then again, the four-factor PCLR, the sort of standard version, does assess one construct. It does measure one thing, as the four facets are highly interrelated with one another. Furthermore, as in terms of the three-factor PCLR, Cook and Michi also removed the antisocial items because they argued that these conflated behavior with personality traits. But then again, a personality trait will encourage a consistent set of behaviors, right? Whereas a consistent set of behaviors can be explained by a personality trait. And sure, the latter is an inference. You are indeed guessing the personality trait based off of the observable behaviors. But this just goes to show just how difficult it is to draw that line between where personality ends and where behavior begins. Anyways, this whole spiel was really just to give you some brief insight into the very much ongoing debate over what role antisocial behavior holds in the definition of our concepts of psychopathy. But, well, as of the time of filming this anyways, our best measures for assessing psychopathy, especially in clinical contexts, do consider antisocial behavior to be a defining feature of psychopathy. Now, this debate also brings us to the much larger problem of defining and assessing psychopathy. Take the PCLR, for instance. It doesn't assess psychopathy per se. Instead, it assesses one conceptualization of psychopathy, one way to see and to describe psychopathy, if you will. And this detail, though as small as it may seem, is incredibly important to highlight for two main reasons. First of all, many researchers and clinicians alike describe the PCLR as the gold standard, not a gold standard, mind you, but the gold standard for assessing psychopathy. And secondly, many are now starting to argue that we are now equating the assessment tool of psychopathy with the actual theoretical construct of psychopathy itself. For instance, researchers Scheme and Cook highlight that, well, as the PCLR was designed in a correctional environment, through framing criminality as central to psychopathy, the PCLR both over-includes antisocial and criminal psychopaths, but also under-includes non-antisocial and non-criminal psychopaths. So, in other words, though the PCLR does an excellent job at detecting criminal psychopaths, it does a poorer job at detecting non-criminal psychopaths. In a follow-up paper in this ongoing debate, the same authors further point out that using the PCLR to test different other constructs of psychopathy inherently doesn't really make sense. Indeed, the PCLR is designed to assess one construct, one conceptualization of psychopathy, right? So it will inherently be an inappropriate tool to use to measure other different constructs of psychopathy. In other words, the authors are asking, how can we say which construct of psychopathy is most valid, say between the criminal psychopath as described by Hare and the non-criminal psychopath described by Clickley? How can we say which of the two is most valid when we rely so much upon the PCLR designed to assess one of these constructs but not the other? Overall, these authors are metaphorically ringing the bell, saying that our over-reliance on this one single assessment tool, both in research and notably in clinical practice, might risk hampering our ability to not only expand on our understanding of psychopathy, but also outline new definitions for this construct and, importantly as well, develop new assessment tools for this construct. Now, this problem of assessing and defining psychopathy isn't just a fun scholarly debate that is entirely theoretical either, because there is growing evidence for multiple different types of psychopathy who differ not only in terms of etiological background, so in terms of the development of the disorder, but also in terms of personality traits and behaviors. And now, this is a problem obviously because you don't want a very specific personality and behavior construct to apply to a group of people who show very different personalities and behaviors. So, in other words, a highly heterogeneous group. In a review of the literature examining this very problem, Yildirim and Dirksen highlight research that point to the existence of primary and secondary psychopaths who differ in a number of important ways. For instance, primary psychopaths are described as less impulsive, less anxious, and show less reactive aggression compared to secondary psychopaths, but also demonstrates more overt forms of narcissism, such as social assertiveness and self-assurance. Furthermore, secondary psychopathic offenders manifest significantly more pathological personality traits, such as borderline personality disorder, and poorer clinical functioning compared to primary psychopathic offenders. Finally, though a gross oversimplification of the matter, the development of primary psychopathy is thought to be greater associated with genetic vulnerabilities, whereas the development of secondary psychopathy is thought to be more associated with external factors such as trauma and the environment. Despite these major differences, the PCLR by itself cannot distinguish between primary and secondary psychopaths. As attempted to do so by Newman and colleagues, they distinguish between these two types by saying that primary psychopaths were those who scored 30 or above on the PCLR plus showed low anxiety, whereas secondary psychopaths were those who scored 30 or above on the PCLR plus showed high anxiety. However, the PCLR doesn't directly assess anxiety, so you have to either infer the patient's anxiety based off of your interviews and perhaps maybe some of the PCLR responses, or just use a different test. In sum, despite the many well-deserved merits of the PCLR, our fixation on this assessment tool and on the four-factor model and the conceptualization of psychopathy hinders our ability to push beyond our current theoretical and practical understandings of psychopathy, as put by MacDonald and Iancoco.
A great deal is known about antisocial personality disorder, criminality, and the psychopathic offender, as defined by the PCLR. Much less is known about psychopathy, especially outside the prison population.
Despite my tirade on the four-factor model of psychopathy and the PCLR, there do exist other conceptualizations of psychopathy, and I will briefly present one of these which I find particularly interesting, the triarchic model of psychopathy. Unlike previous conceptualizations of psychopathy, which were formed based on actual observations of offenders and patients and such, the triarchic model of psychopathy instead was built entirely based on the literature of psychopathy, with an expressed and intense goal to reconciliate, to bring together these different conflicting conceptualizations of psychopathy by drawing three overall traits of psychopathy which were consistently observed in the literature. These being boldness, which encompasses social dominance, venturesomeness, and emotional resilience; meanness, which encompasses slow empathy, callousness, and aggressive manipulation of others; and finally, disinhibition, which encompasses boredom proneness, lack of restraint, irritability, and irresponsibility. To take a quick step back and look at the previously mentioned conceptualizations and types of psychopaths we discussed. From the perspective of the triarchic model of psychopathy, the conceptualization of psychopathy expressed by Cleckley emphasizes tendencies of boldness plus disinhibition, whereas the conceptualizations of psychopaths based off of criminal offenders, such as that of the PCLR, emphasize tendencies of meanness plus disinhibition. In terms of primary and secondary psychopaths, primary psychopaths show higher tendencies of boldness than secondary psychopaths, who in turn show higher tendencies of disinhibition, and when assessed using a different tool, also higher tendencies of anxiety and neuroticism. Anyways, to keep this part short, an important strength of the triarchic model of psychopathy is that it is a multifaceted dimensional model, and therefore can explain a lot of the heterogeneous group of psychopaths that we now observe today. Well, now, given this lengthy debate, where does this all leave us? What exactly is psychopathy? Well, as usual in psychology, the answer is it depends, really. Although we don't yet have a clear end-all be-all definition for what psychopathy is, despite all of the disagreements, the arguments, the debates, there are some clearly consistent and recurrent points. Typically, the literature agrees on certain traits, such as shallow affect, lack of remorse, superficial charm, poor interpersonal relationships, and the like. However, other traits are highly debated and are highly contentious, namely anxiety and neuroticism and antisocial behaviors, which depend far more on which conceptualization of psychopathy you subscribe to, but also in what environment the psychopathic patients or offenders find themselves in. Namely, is it psychiatric or correctional/institutional? Though this scholarly debate is still very much ongoing. In terms of clinical and legal practice, however, they lag behind in this department. Indeed, in such practices, a psychopath is merely defined as someone who scores above 25 or 30 on the PCLR, a definition that, after all of this debate, can seem both oversimplistic and infuriating. And yet this real world, this practical definition of psychopathy has many consequences, such as the treatment of psychopathy. Despite the ongoing challenges and disagreements in both assessing and defining psychopathy, there is at least one thing that we can all collectively agree upon. Psychopaths have proven themselves to be incredibly challenging, if not outright impossible to treat. Indeed, many notable scholars have described the disorder as chronic and untreatable, and psychopaths as impossible to rehabilitate. For instance, in the 4th edition of The Mask of Sanity, Cleckley wrote that he was
profoundly impressed by two difficulties that stood in the way of dealing effectively with the psychopath. One of these was his apparent immunity, or relative immunity, from control by the law. The other was his lack of response to psychiatric treatment of any kind.
This sentiment is also shared by the PCLR manual, which emphasizes that.
Clinicians and researchers are rightly pessimistic about the treatability of psychopaths with traditional methods.
Likewise, forensic practitioners are at best skeptical over the treatability of psychopathy. Indeed, in one survey, only 1% of UK forensic practitioners agreed that psychopathy is always remediable. Instead, most practitioners agreed that psychopathy could only benefit in certain cases of treatment. In another study, Swedish practitioners overall agreed with statements there is no treatment that can cure psychopathy, and that psychopaths can never change. They will always be psychopathic. These practitioners also overall disagreed with the statement criminal psychopaths can be rehabilitated. Unfortunately, however, these scholars and practitioners are quite rightly justified in their sentiments. Indeed, many personality traits and behavioural patterns of the prototypical psychopath inherently pose obstacle to treatment. Indeed, most psychopathic patients are generally poorly motivated to pursue treatment and to change, especially when this becomes either challenging or simply enough inconvenient to them. Indeed, although pain and anxiety are excellent motivators for patient change, their relative, if not total absence in the psychopathic patient clearly limits their effectiveness for motivating change, right? Furthermore, total PCLR scores show significant associations with treatment evasiveness, argumentativeness, hostility and resistance to change, lower commitment and likelihood of completing treatment, and poor treatment progress. On top of this, PCLR total scores are inversely related to patient-therapist ratings of working alliance, meaning that psychopathic patients form weaker therapeutic bonds with their therapists. Note, of course, that increasing therapeutic alliance throughout treatment predicts greater treatment change in high-risk, violent psychopathic offenders. And last but certainly not least, psychopathic offenders recidivate significantly more violently on average compared to non-psychopathic offenders. Therefore, overall, most defining traits of psychopathy pose serious challenges for successful and continued treatment. Not only are psychopathic patients the complete opposite of your ideal therapeutic patient, but overall, unfortunately, psychopathic patients respond less to treatment than non-psychopathic patients. Now, of course, other forensic populations, such as those with antisocial personality disorder, are also incredibly difficult to treat. And yet, psychopathy has a discouraging and negative history when it comes to attempts to treat it. For instance, in the now classic and highly cited paper, Rice and colleagues retrospectively examined the effectiveness of a highly intensive 2-year therapeutic community treatment program. After a 10-year follow-up, the authors found that treatment was associated with significantly higher rates of violent recidivism in psychopathic patients, but lower rates of violent recidivism in non-psychopathic patients. So, in other words, treatment made psychopathic patients worse. The authors explained these results by arguing that
community treatment programs that generally seek to cultivate pro-social, empathetic, and caring qualities might inadvertently make psychopaths better equipped to facilitate the manipulation and exploitation of others. And such treatment efforts could therefore be associated with novel ways to commit violent crime.
Other therapeutic community treatment program studies also found similarly discouraging results. In one such study, PCLR factor 1 scores were significantly related to negative behavior during treatment. And in another study, overall psychopathy scores were significantly associated with poor treatment response, failure to complete treatment, and an increased risk for general recidivism. In short, these early studies concluded that efforts to treat psychopathy were, at best, largely ineffective, but at worst, actively made psychopathic offenders more violent, more criminal, and more dangerous. It is difficult to overstate just how much of an impact these early studies had, especially that paper by Rice and colleagues. Indeed, many forensic treatment programs just started outright denying treatment to offenders who had high PCLR scores. And furthermore, with such seemingly clear-cut answers, there was far less motivation to keep on looking, to keep empirically examining whether psychopathy can or cannot be treated. Furthermore, with the experiences and beliefs held by clinical practitioners, this seriously negative stigma started to form around psychopathy, namely that it is untreatable. To quote Swartfeld and Landon,
even a quick review of the literature suggests that a chapter on effective treatment should be the shortest in any book concerned with psychopathy. In fact, it has been suggested that one sentence would suffice. No demonstrably effective treatment has been found.
Well, then again. Much like many classic psychology studies, such as Milgram's obedience studies and the Stanford prison experiment, the findings of Rice and colleagues, these highly influential findings, were, how to put it, less than squeaky clean, to say the least. Yes, the authors did find that treated psychopathic patients recidivated violently significantly more than non-treated psychopathic patients. And yes, the authors did find that treated non-psychopathic patients recidivated violently significantly less than non-treated non-psychopathic patients. And yet that's not quite the full extent of the findings of the paper, because notably all psychopathic patients recidivated to a similar extent, whether or not they underwent treatment. And furthermore, the authors admitted that their matching procedure between treated and non-treated patients wasn't perfect, meaning that there could have been other factors at play that influenced the results of the paper other than just simply treatment condition. In other words, whether the patients were treated or not. And finally, when I say that this treatment program administered in the 1960s at the Oak Ridge Social Therapy Unit was compared to torture, I wish that I was exaggerating. Indeed, patients were administered hallucinogens and sedatives to artificially augment disclosure. They were likewise subjected to nude encounter groups and were deprived of their senses. In other words, the key components of this, at the time, revolutionary and groundbreaking treatment program were based on principles of brainwashing in Chinese prison camps. And what is easily the biggest red flag of this whole debacle, in my eyes at least, is that entry to and participation in the treatment program was not voluntary, and patients could not leave the treatment program without first convincing staff that they made clinical progress. Even the authors agreed that at the standards of 1992 at least, quote, several aspects of the program might be seen to violate patients' rights. A class action lawsuit was raised against this institution and its practitioners, and in May 2017, the judge ruled in favor of the plaintiffs, comparing the alleged treatment to torture. Looking back at these patients, it's no real wonder to see why many of them, after release, ended up reoffending. Take Jim, for example, who, after being released from the Oak Ridge Center in 1976 was completely broken down and dysfunctional.
I wasn't ready to be on the street. I couldn't function on the street at that time after
And you were
penitentiary
angry.
machine. And I was angry. Yes, I was angry. I hated them. I hated what they did. I hated what they stood for. That anger, and I couldn't control the anger. I'd lost any ability to get hold of that anger.
Now, let me be clear that we are not faulting Rice and colleagues for the treatment program, okay? They had no influence over its design or administration. All they did was collect the data and analyze it. And furthermore, we shouldn't either fault them for the initial success of the paper. Indeed, given the such clear-cut conclusions, it's no wonder that it had such an impact on early perceptions of psychopathy treatability. However, in Harris and Rice's 2006 review of the psychopathy treatment literature, that 1992 paper played a crucial role in their overall conclusion that psychopathy is untreatable, despite the fact that the Oak Ridge Social Therapy Unit was already facing legal action as of the year 2000. Furthermore, in Salekin's 2002 review of the literature on psychopathy treatment, they found that of the 42 reviewed papers, only one reported significantly negative adverse outcomes for treatment. That flippin' 1992 paper by Rice and colleagues. Salekin's review specifically noted that overall across the literature, 62% of psychopathic patients benefited from treatment. The most effective treatment modalities or types being cognitive behavioral therapies and psychoanalytic psychotherapies, with the worst modality reviewed by far being therapeutic community programs. Furthermore, the review also highlighted the poor quality of the overall research on the question of psychopathy treatability. Now, even if we do question the arguably optimistic conclusion of Salekin's review, namely that the therapeutic pessimism with regard to the psychopathy treatment relation is not warranted, at least the review points out that because of the overall poor quality of the research existing so far, it's not possible to say for certain one way or the other whether psychopathy is or is not effectively treatable. Now, I wish that this review was a turning point in the pessimism and stigma of psychopathy treatments, an excuse to redouble efforts to look further into this question with high quality research. But instead, clinicians and researchers held on to this unfounded stigma. For instance, the PCLR's manual, published in 2003, barely mentions the findings of this review, merely declaring that
although some reviewers have suggested that clinical pessimism might be replaced with clinical optimism, most clinicians and researchers are rightly pessimistic about the treatability of psychopaths with traditional methods.
And to make matters worse, despite Salekin highlighting the poor scientific basis for this pessimism and this stigma, the authors of the manual further insisted that
some clinicians and administrators hold the uncritical view that psychopaths who have participated in prison treatment programs must have derived some benefit. This may help to lull the criminal justice system and the public into the false belief that psychopaths with whom they must deal have derived tangible benefits from treatment simply because they and their therapists say so. Many psychopaths take part in all sorts of prison treatment programs, put on a good show, make remarkable progress, convince the therapist and parole board of their reformed character, are released and pick up where they left before they entered prison.
despite this general unwillingness to let go of the stigma and pessimism, in the last decade or so at least, there is growing discussion, growing argument to point out that we just do not have the evidence to conclude for sure that psychopathy is indeed untreatable. For instance, in Salekin and colleagues' later review of this literature, they highlighted that the research does not necessarily lead to the conclusion that psychopathy is untreatable. Indeed, the authors did note that adult psychopathic patients could benefit from standard treatment programs. And furthermore, in a later review by Polaszek and Scheme, the authors did find evidence for positive treatment outcomes, but concluded that providing any conclusive or definitive answer was challenging due to the scarcity of research. A point that is quite ironic when you think about it, as the authors argue that this scarcity might be in part propelled by the fact that practitioners and researchers alike believe that they already have the answer, namely that psychopathy is untreatable. It's a self-fulfilling cycle problem. Why is there so little research examining whether psychopathy is or is not treatable? Because practitioners and researchers believe that they already have the answer. Now, why do practitioners and researchers believe that psychopathy is untreatable? Because they can't say for sure that it is, because of the poor quality of research in the first place. In other words, an important takeaway point of Polaszek and Schemes' review is that we just need to get the ball rolling, right? To actually start empirically examining, using high quality research methods, whether psychopathy is or is not treatable. At least through this process, we will have far better studies of far higher quality to base our clinical and legal policies on, rather than solely on a stigma that has little to no scientific basis. I cannot stress this point enough, because the consequences of this unfounded stigma are very much real. As I mentioned previously, therapeutic treatment programs do deny treatment to offenders who have high PCLR scores, and furthermore, forensic practitioners are generally at best skeptical over whether psychopathic patients can be treated. However, this bias also extends itself to the courtroom. Indeed, defendants perceived as psychopathic by lay jurors often predict longer sentence lengths, harsher capital punishment, and a greater pessimism for the potential to be rehabilitated. As you can see, hopefully, unfortunately, psychopathic patients end up being caught up in a catch-22. Indeed, on the one hand, these psychopathic patients are told that they cannot be considered for release nor parole unless they undergo and complete treatment programs. But yet, on the other hand, they are also refused access to these treatment programs on the grounds of their PCLR scores, again because of this unfounded stigma. Another twisted irony to all of this is that, according to our very best forensic treatment guidelines, psychopathic patients should be targeted with our very best treatment efforts. Indeed, according to R&R guidelines, treatment should match in intensity to the level of risk posed by the patient. It should also change empirically established correlates of criminal risk, such as impulsivity and criminal attitudes, i.e. the criminogenic needs. And finally, treatment should be delivered in a manner that maximizes the patient's engagement in the treatment process. Looking back at our psychopathic patients, we know already that psychopathy, namely a high FACET 4 score, significantly predicts future recidivism, and therefore these patients are considered as high risk. In other words, right from the get-go, we are already failing the most fundamental principle of forensic treatment, that being risk. So in other words, rather than throwing everything we have towards these patients for treatment because they are psychopathic, instead we withhold treatment from them because they're psychopathic. Of course, it is far easier for me to say, go treat psychopaths, than actually treating psychopaths in practice. I get it. So, what would this treatment actually look like? Well, typically when we say treating psychopathy, what we usually mean is reducing future risks of recidivism and criminal behavior, as that is indeed the primary goal of forensic treatment. In line with this, one treatment approach that is showing some promise are cognitive behavioural therapies, or CBTs. In short, these target the patient's maladaptive core beliefs, which are beliefs that are essential to the patient's identity as they drive thoughts, rules and behaviours, but are both negatively biased and also inaccurate. For example, take the maladaptive core belief, I am unlovable. This core belief may in turn drive the conditional rule, if I am thin, then I will be loved, which in turn may drive obsessive behaviours over one's appearance and even disordered eating habits. So, in short, CBTs aim to teach patients to understand their current ways of thinking and behaving, and provide them with the tools necessary to target and change these core maladaptive beliefs and behaviours. In such a treatment program, Oliver and Wong found that psychopathic and non-psychopathic sex offenders who did complete the 6 to 8 month treatment program were similarly less likely to recidivate violently and sexually over the 10-year follow-up period. However, the authors did note that about 25% of the psychopathic sex offenders did not complete the treatment program and were more likely to violently but not sexually recidivate during that 10-year follow-up period. Now, this last point is in line with research that points out that treatment non-completion, i.e. treatment that patients start but do not complete, is associated with increased risks of recidivism, especially compared to patients who just do not undergo treatment at all in the first place. And yet, this point shouldn't undermine the fact that this study found that treatment completion and treatment change did reduce rates of recidivism, both violent and sexual, in psychopathic sex offenders. In a later study, the same research team found that through CBT treatments, greater positive therapeutic change in psychopathic sex offenders was associated with a lower risk of reconvictions for violent offences. Just overall, these studies document that greater therapeutic changes, positive changes in psychopathic offenders undergoing and completing intensive CBT treatment was statistically associated with reductions in future risk. And this is quite notable as these CBT treatment programs in the first place were not explicitly designed to treat psychopathy. To address this point, Wong and colleagues proposed a two-component model for treating psychopathy, the Psychopathy Treatment Program. In short, whereas Component 1 manages the PCLR Factor 1 traits, Component 2 specifically treats the criminogenic need associated with the PCLR Factor 2 traits. So, as you can guess, this treatment method is specifically designed with the PCLR in mind. Although no study has specifically examined the effectiveness of the psychopathy treatment program, Wong and colleagues have pointed to 3 separate studies that they deemed consistent with the two-component model. In short, these studies found that for both violent and sexual offenders with high psychopathic traits, risk reduction assessed during and throughout treatment was associated with significant reduction in both violent and sexual recidivism post-release. As you might have noted, however, is that this two-component model for treating psychopathy overlaps perfectly with the 2 factors of the PCLR. So, in other words, this treatment approach conflates the PCLR assessment tool with psychopathy itself. Now, this doesn't strictly mean that we should entirely reject this treatment approach, but instead, much like how the PCLR is good at assessing certain types of psychopaths, but not necessarily others, perhaps this two-component model for treating psychopathy is best for treating certain types of psychopaths, namely that assessed by the PCLR, but maybe not other types of psychopaths. With all of that, we can now finally bring our attention to schema mode therapy, which was initially designed for treating patients with severe personality disorders, but was since adapted for use with forensic patients. In short, This treatment approach proposes that criminal behavior can be explained by a series of or a chain of maladaptive schemas, which are automatic emotional, cognitive and behavioural scripts that we use in our day-to-day lives. Take this simple case study, for example. You have a patient who is extremely paranoid. They are in the paranoid over-controller mode. And perhaps one day they convince themselves that all of their problems in the world are caused by one single person. And they think that, well, if I get rid of this person somehow, then all of my problems will disappear. So maybe then they shift into the predator mode, which sounds as scary as it is, because in that mode, that patient then eliminates that person in a very much cold and calculating and callous manner. Hopefully in that short example, you can see how by breaking down the series of events leading to the offence into these different modes, we can figure out throughout treatment which of these modes can be targeted to be changed so that in a future similar triggering event, a different series of schemas instead occur, which hopefully would avoid any criminal activity occurring. As far as I'm aware though, there are 2 studies that examine the effectiveness of schema mode therapy in treating psychopathy. In one of these studies, preliminary findings of a multi-center randomized clinical trial with forensic patients with personality disorders suggests that treatment reduces future risk of violent behavior compared to treatment as usual. Although the paper did not specifically examine the interaction between treatment outcome and psychopathy, the authors did note that the group undergoing schema therapy consisted of a far greater number of highly psychopathic patients compared to the treatment as usual group, despite the former group having far more successful outcomes. Finally, to make a brief point about the treatment of primary and secondary psychopaths. Although it was predicted that secondary psychopaths would be more receptive to treatment efforts compared to primary psychopaths because their psychopathy developed more so through environmental factors and trauma, this doesn't quite appear to be the case as of right now. Indeed, although secondary psychopaths do show greater motivation to pursue treatment as compared to primary psychopaths, in terms of examining responsiveness to treatment efforts, though secondary psychopaths show greater responsiveness compared to primary psychopaths, this difference is non-significant. And furthermore, when we examine recidivism rates during a 1-year follow-up post-release, these differences are also non-significant between the 2 groups. So overall, although secondary psychopaths do show greater motivation, in terms of actual responsiveness to efforts and in terms of reducing recidivism risk, the differences between primary and secondary psychopaths appear to be non-significant. As of right now, however, because this literature is so incredibly shallow that we simply just do not have enough evidence to conclusively say for sure that whether or not there are differences between these 2 types of psychopathy in terms of treatment outcomes and all of that. So all in all then, in terms of reducing future risk of violent and criminal recidivism in psychopathic offenders, these studies do at least point in the direction that these intensive therapeutic programs, these intensive interventions are at least somewhat effective. And this, at least to me, is quite noteworthy, as these interventions are not explicitly or specifically designed for treating psychopathy, but rather for targeting high-risk offenders. And despite the optimism that these studies provide us with, in a sense, because none of these studies used a randomized methodological design, right, which is the gold standard for research like this, at best these papers can only provide a suggestion rather than a conclusive answer to our question. Furthermore, let's not forget that psychopathic patients, psychopathic offenders, are probably some of the worst kind of therapeutic patients you could ever hope for. They're confrontational, they show poor motivation to pursue treatment, and they have very poor relations with their therapists. And furthermore, psychopathic patients on average quit treatment sooner than non-psychopathic patients. And remember that treatment non-completion increases your risk of recidivism more so than just never having started treatment in the first place. So there are also risks to providing treatment to psychopathic patients when you look at it that way. In short, this is not a black and white problem. This is we're very much in the grey middle of it. And so this brings us back to our two main problems throughout this video. The first being, well, if you can't provide a consistent and clear definition for what psychopathy is, how on earth are you going to design treatment programs that are specifically designed for targeting these kinds of patients? And second of all, we're back to the problem of, well, we don't have good enough research to answer this question properly. We need more research of better quality with larger samples to start actually better answering this question for certain, rather than just saying, well, some studies suggest that maybe perhaps kind of we need more than that. So it means that right now anyways, the best we can do is to try and reduce the psychopathic offenders' risks for future recidivism, whilst at best just managing their symptoms of psychopathy. This actually begs the following question. Could we maybe treat psychopathy by reducing symptoms, by reducing these traits of psychopathy, such as lack of empathy? And the short answer is, we don't know. There really is hardly any literature that tackles this specific question, especially for adult psychopaths. Now, this is, I think, as good time as any to quickly come back to the triarchic model of psychopathy, as Patrick and colleagues proposed a number of quite creative interventions that they hypothesize could help reduce the traits of boldness, disinhibition, and meanness of their model. For example, they hypothesized that attentional retraining therapy could help the psychopathic patient learn how to better recognize and attend to, or to specifically focus on, cues of distress, cues of fear and sadness emitted by other people, facially or otherwise, which they hypothesize could help reduce the trait of meanness. However, what will probably be the most effective way for reducing the symptoms of psychopathy is to, in other words, snip it in its bud. So in other words, to target it during its development. Now, because we can only diagnose someone as a psychopath after they turn 18 years old, for this part of the discussion, we will be examining youth, so adolescents and younger, who specifically show symptoms for conduct disorder, as well as callous unemotional traits. Indeed, these CU traits are of particular interest to us as they appear to represent the core symptoms of psychopathy, such as lacking guilt and empathy, lack of affect and anxiety, and the callous use of others for one's own personal gain. Indeed, the combination of conduct disorder and also CU traits typically predicts more severe, aggressive, and stable patterns of antisocial behavior that persist into adulthood, more so than just the diagnosis of conduct disorder by itself. However, this doesn't also mean, of course, that conduct disorder plus CU traits systematically equals psychopathy. But because this is one of several hypothesized developmental pathways for psychopathy in adulthood, it is nonetheless of interest to examine whether these psychopathic traits can be reduced in these youth. And fortunately, there is some very recent and quite promising work being done to try and answer this question. apologies in advance for butchering the name, but Ruiter da Silva and colleagues have recently examined the efficacy of a compassion-focused therapy program called Psychopathy.comp, which is specifically designed for reducing psychopathic traits in detained youth, these namely being grandiose manipulative, callous unemotional, and impulsive irresponsible traits. Now, very quickly, this individual treatment program focuses on helping patients become more sensitive to the suffering of themselves and of others, and to help them acquire the strength and motivation necessary to prevent or at least alleviate the suffering, rather than just continue on to see the world as this threatening predator eats prey world. The authors specifically found that in terms of the measured traits, so callous unemotional, grandiose manipulative, and impulsive irresponsible, all of these traits decreased significantly in youth who underwent the Psychopathy.comp treatment program. In fact, the youth who instead underwent treatment as usual maintained, if not even showed increased levels of psychopathic traits over time. Now, of course, these results and findings need to be replicated with different samples, blah, 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 blah. But it shows early indication that this treatment program specifically designed to target and reduce symptoms of psychopathy might be effective in youth. Finally, I cannot just talk about the subject, about treating psychopathy and the like, without at least mentioning the case study of Andy, the treated psychopath, who, following a serious sexual assault, underwent 4 years of intensive forensic treatment, which notably included chemotherapy. In just a few quick words, after his 4 years of intensive treatment, his antisocial modes, namely, for example, the predator mode and the Boolean attack mode, were scored as significantly less prevalent at the end of his treatment compared to at the start of his treatment. And furthermore, his PCLR total score dropped from 28 pre-treatment to just 14 post-treatment, with notably significant reductions in the interpersonal and affective facets. In addition, Andy's risk of future violence as measured by the HCR20 decreased from high pre-treatment to medium post-treatment. And finally, when interviewed, Andy appeared to show genuine remorse as to his past offences. Of course, as this is just a single case study, this is not irrefutable proof that psychopathy can indeed be treated, both in terms of reducing risk and in terms of reducing symptoms. Nonetheless, this is a patient, this is a person who, after 4 years of intensive forensic treatment, showed lowered levels of risk and a decrease in major symptoms of psychopathy. So, in other words, it's a start. So, in conclusion, all in all, where does this leave us now? Well, if there's one thing I hope you take away from this video, is that ultimately, it just depends. Can psychopaths be treated or not? It depends. What are the best means to measure and assess psychopathy? It depends. What even is psychopathy? It depends. It depends on who you ask. It depends because we don't have good enough research. And I hope that makes your blood boil. I hope it drives you insane that we cannot have conclusive answers to these questions. I hope that it drives you to try and find these answers yourselves in the literature, which honestly I feel like I've barely scratched throughout this video because there's just so much of it out there. And I hope that if you are in a position to do so, that you could try and answer these questions, to answer what is psychopathy, to answer how can we better measure and assess it, and to finally answer how could we treat the untreatable. Thanks for watching. Hello dear viewer, and welcome to the end of the video. We genuinely hope that you enjoyed watching this admittedly long video with a lot of content and information inside of it. So honestly, hats off to you for making it to the end of the video. Obviously, we also need to thank, of course, the University of Limburg's funding program, SWOL, for giving us some funding to actually get the materials and software necessary to actually make these videos. So genuinely, thank you so very much. All of the references are in the link below. There's a Google Docs where you can find all of the references that we used in this video. And if instead you want to find something a little bit easier to dig your teeth into first, well, I actually can recommend a couple of really fantastic chapters. And the best thing is that you can find them for free by just searching up the titles. And yeah, thanks for watching.